Wait, this and your shirt. Oh my god, being people. Where did she go? Right. Yeah. Right. Yeah. That's weird.
I know, that's how I know.
I don't know what the last slide was.
Delicious. That's great. It's good. Yeah. like it. I mean, I just, it's too It's gotta be done.
I'm Tasha. Yes, my brother's 6 years. I'm like a dog with my dad. Yeah, yeah. No, I think y'all are actually. Yeah. But my little brother. Oh, that's the new. Yeah, like dogs, yeah. What part of
Yeah, I got all.
So it's when you email me and I will learn. A lot of them.
Yeah. I should be.
Everybody was like, monitor. Oh my goodness.
Good morning, everybody.
Okay.
Come on, good morning, everybody. All right. So we may have people sort of lumbering their way in. Everyone reminds me when I said, why is it taking folks to get around? Why is the traffic so bad here in Austin? He said, well, it's raining. So, and that's such a rare occurrence here. We need to accept it and take it in every time it happens. So thank you everyone for being here. My name is Jeff Richardson. I'm the CEO at Integral Care, and we've got a lot to go over today. So I'm gonna try and be as speedy talker as I can. These guys were kind enough to give me a few extra slides to give a little background, but we have a great panel for you today. So hopefully we'll have plenty of time for our panel. And also, while we're going through this, if you've got specific ideas or thoughts or questions, please, we'll have time for questions at the end. So thank you all for being here. Before I get started, do we want to introduce all of our panelists, Kathleen, or you want me to wait to do that later?
This is fun.
This is great.
Captain Casey, Chief Strategy and Innovation Officer with Integral Care.
Sergeant James Turner, I'm the sergeant over our crisis intervention team program as well as all our various mental health programs.
I'm Dawn Hanley, I'm the Chief Operations Officer and Vice President for Integral Care.
Sydney Harris, I'm the Senior Consultant, Health Systems Design at Central Health.
I'm Dr. Mark Escott. I serve as the Chief Medical Officer for the City of Austin.
Andy Brown, I'm the Travis County Judge.
Also want to do a shout out for my fabulous board leaders from Integral Care, Trish Brown and Hal Katz. All right. So we're going to jump right into things, guys. And I don't think I need this mic. My job is even better. You know, really what we're going to go through is a few things today. I'm going to give a little bit of background. And once we finish going into some of the background, we're really going to jump into some very specific questions for our panelists where Dr. Casey will help convene and keep the conversation going. And then we'll have a chance for QA. So really, you know, I promise you I won't read what's on all these slides, but I hope all of you, if you would like a copy of these slides, let us know. We'll give you a copy of them because there's a lot of detail and depth to these. But suffice it to say, we wanted to start off by talking about how impactful and how important, if you haven't, many of you are here because you really deeply care about behavioral health services here in Travis County. There's a huge need, and we're not meeting all the need yet. We have an enormous amount of work to do to meet all the needs in our community. Right now, nearly 23% of adults experience mental illness in the past year. And so, assuming we've got about 1 million of our 1.4 million in Travis County as adults, how many of you math majors out there? That's a lot, right? That's about 230,000 folks in any given year. And many of those folks are not accessing care in the way that we think would be most efficient and effective for them. The other is really important to identify is that we also have nearly 17% of the population meeting the criteria for substance abuse disorder in the past year. One of the great news, and Judge Brown brought this up actually last week at the state of Travis County, we've seen a tremendous drop off of fentanyl deaths. But we still see a large and a high need of folks who are using addicted substances. It is a huge problem in our community and a continued need for us to address. Nearly 15% of adolescents aged 12 to 17 reported experiencing a major depressive episode in 2024. And nearly 9% of the children have at least one diagnosed developmental disability. And as many of you know, under developmental disabilities, we're also talking about diagnostic needs like folks on the autism spectrum, which is a growing and a rapidly growing need in our community. In this county, our mental health needs are widespread. And again, one of the studies that Austin Public Health did in 2023 was 34% of Travis County adults reported experience 5 days or more of poor mental health. That's pretty significant and noteworthy. And the community health assessment that's done every year by Austin Public Health identifies some key areas. One, mental health distress is widespread. Housing instability undermines health and access to care, right? If you don't know where you're going to live, your mental health obviously is not a peak experience for you, right? Substance use and overdose deaths are on the decline, but continue to pose a risk. And again, addiction has not gone away. There's other ways that people are enduring and challenged with addiction. And as we've seen all along in the great, big, beautiful HB1 bill, there's going to be a reduction in access around Medicaid and other care for folks as that continues to progress. So we're also going to see growing gaps across our community, which affects people's access to mental health care. We have a number of people that are no longer able to afford buying health care on the exchange. So there's more people having to make decisions about gas versus taking care of themselves. Very tough decisions. So I sound like a ray of sunshine in this rainy day, don't I? Yes, Jeff. So, you know, really, as we said earlier, our population in Travis County is nearly 1.4 million. In the wider metropolitan area, we're talking about nearly 2.55 million people. And growing, right? And, you know, the Central Texas growth is an increasing demand for all of these services I just described. There is a huge demand, and it just continues to be. Many of you do know what integral care is, but we could talk about statistics, but behind every statistic, there's a person, there's a family, there's a community that we care for. And our role is as a local mental health authority is both a provider, a coordinator of care, and helping convene and raise the level of need and support our communities in a variety of different ways. And we have been around since 1967. So we need to keep growing as our community grows. So when we talk about behavioral health, It's not just one thing, one person, one service that really makes a difference in this community. And as you can see on this panel, we have a lot of folks who represent a variety of different ways that we need to address and keep responding to the needs of our community. Along with, when people think about behavioral health care, you're thinking about going to see a psychiatrist to get treatment. But there's so many other things that we do and our community does to prevent and promote and intervene early and respond to both crisis and in recovery. All of these pieces are critical. All these ingredients are critical for us to be successful as a community. And so everything, many of you have been through things like mental health first aid. How many mental health first aiders in the room? Woo-hoo. All right. 20,000 that we've trained at Integral Care. So very proud of that. We need to double, triple, and quadruple that now. But we really, all these features are critical for our success and being able to intervene in our community. If we invest all of our resources in crisis and recovery without doing early intervention and prevention, we've lost the battle before it started. So there's so much work we have to do to help ensure that. And all of you in the roles that you play in this community are vital to help making that happen. So as I said earlier, we have a number of things that we do at Integral Care, from 24/7 mental health crisis response, to children and family services, to intellectual and developmental disabilities, to a range of other things that we do in our role as a provider. In our authority role, which is one that we coordinate both a network of other providers, we provide education and training. We serve and manage access for a wide variety of folks that are not, we're providing services, but we're contracting for care in the community. We do network development, and we create a local plan. And if you look at our website, we put together a plan annually to define what our overall needs in this community are. It's actually not a painful read, but if you're struggling with sleep issues, please stop by at 3 a.m. and I'm sure there's other folks there who could answer questions for you once you read it. And then, again, a lot of the work we do is around strategic planning and coordination. One more last slide about Integral Care, and that is, these are the number of folks that we served. Last year was about 29,000 folks, and many of those used multiple types of services from us. Along with that, BIPOC clients, nearly 63%. And so we are an important resource for our community. What's incredibly telling is the number of folks in poverty that we're serving, nearly 97%. And that tells you what the impact mental health and lack of mental health has on people's ability to work, to thrive in our community, to maintain their housing, all the things that are vital for our ability to function day in and day out. And nearly 1 in 5 of the folks that we serve are experiencing homelessness. So there is a huge need in our community to continue to respond, particularly for this most vulnerable population of folks that are unhoused, that are struggling with mental health needs. Having these services are vital to help all of those things work so closely together. One of the things that I'm most proud of is our call center and our helpline. And last year alone, we nearly took 200,000 calls. And in that space, we have both a 24/7 helpline where anyone can call for any kinds of needs in our community. And our job is to both help identify what that need is and link people to care. In other cases, it's helping to respond and connect with our first responders, and we'll talk about that in a minute. We also are the 988 call center for 70 counties, 70 counties in Texas. And in that role, we're also linking people to care locally in their community, as well as what we do in Travis County. And so one of the other things that's really important that thanks to our county, city partners, we've been able to expand our psychiatric emergency service to 24/7. So we have the ability to provide services 24/7. And with that, it's been tremendous. We've served nearly 6,000 people last year. It shows you what that demand for that service is. It allows us to do a walk-in resource, but also first responder drop-off. So we have a number of our first responders that drop folks off there as well. And there, it could be everything from identifying someone needing an inpatient bed to actually responding and getting someone an appointment on the spot, or we have both observation beds and ability to link people to inpatient capacity when needed. So 2 more slides, I promise you. How am I doing, guys? Good? All right. You're still with me? Okay. There's coffee back there. No, there's not. There's water. So, all right. You're good. And then, what's important to talk about too is the amount of people that we provide housing and housing support services to. In last year, we served nearly 4,000 people in a variety of both homeless prevention, providing affordable housing, permanent supported housing, and rapid rehousing. All of these things are critical to someone's mental health. And again, serving a population that's most vulnerable, but that housing itself and housing alone is not sufficient to ensuring someone's success. Being able to provide those support services. And I also want to thank our city and county and Central Health partners for helping us support this. Without them, we would not be able to do any of this. And this is a uniquely vulnerable population of people that we serve. These are folks struggling with mental health needs. Many have co-occurring medical conditions, many of whom need that ongoing support to help them maintain that housing. If all works well, then they're not folks who are showing up at crisis or are being arrested or in our jail system. The other thing that we've identified specifically is really significant barriers around transportation. And as we look at where people are moving to, not every place is accessible by a bus. Frankly, someone told me those helicopter cabs are coming soon. Maybe that will resolve if you're stuck in traffic. I would love that concept. But it's really part of what we see is we need to do more and more to be able to reach people where they are, physically not expect them to come in. Telehealth is a plus for some folks, but still in-person contact is what we want to do and is the gold standard. And then what we've done to respond to that, and you guys have seen some of our vans around, we have actually a third van coming now to provide on-site and in-community services across Travis County. So the last thing I wanted to just talk about, because we have so many of our police partners here today, and how important it is for first responders and our partnership with the city and the county. We've been embedding mental health clinicians at our 911 call center, and I'll talk about that in a minute. Tremendous results, and actually we had a study done that was just published, literally just published with Cornell University and a number of other partners to help define how successful that intervention really is. And we were the first in the country to do this. Expanding mobile crisis out teams. Our Austin First, which is a co-response with Austin Police Department and EMS, again, dealing with some of the folks that are most challenged with medical, criminal justice issues and mental health issues all at once, is a really important strategy for a high-touch, high-need group of consumers. We've talked about our PES drop-in capacity, our integral care host, a team that is providing collaboration with Austin Police Department, EMS, and the Downtown Austin partnership, really to target downtown specifically and support those folks who are really struggling, that are kind of our returning customers to our system, and be able to intervene at the right place. The diversion center work, and again, we are so proud of the pilot that the county has supported, the city has helped support, and Central Health has helped support. It's showed tremendous results in terms of both the interventions we're providing at PES, but in the therapeutic diversion program itself and the housing. It shows when you're actually able to wrap around services to people at the right time, the right place, it can deliver on results. And so, again, everybody in this room was involved in supporting this. We want to thank the county's leadership in particular for getting us here. And then, we do a lot of work around sharing protocols and systems design, and our sheriff isn't here this morning, but one of the work we've done with the county in particular is data exchange, being able to share data with the police department and integral care. And data exchange is a really core way of helping people ensure they get continuity of care. And we have a lot more work to do in that space. So I'm not going to go through all of this, but just suffice it to say, one of the things that we've looked at, and we have data, if any of you want to see it, if you like spreadsheets, or if you like Claude, or your favorite AI tool. But one of the things we looked at and we've done research on specifically is cost avoidance with these programs. A lot of the services we do, if we do them, we save money and resources down the line and support people being able to do the work they have. 911 in particular is the study I just mentioned that we had done about the 911 program. And one of the really important pieces of this data is that 43% were a reduction in involuntary emergency detentions, which was fabulous. 34% reduction in arrests, and over 50% reduction in officer time spent if we are able to intervene at the right place and right time for folks. And again, these services identify if you're able to put behavioral health services at the right place and the right intervention, they reap tremendous rewards. So I went through a lot of information very quickly, but you've heard enough of me, and I'm going to hand it over to a much more capable facilitator, Dr. Kathleen Casey.
Morning, everyone. I'm going to do a quick time check because I know Judge Brown needs to make an early departure due to a prior commitment. You heard Jeff talk about the need for really, really effective crisis response. We aim to go way upstream to do effective prevention, promotion, early intervention, but about 50% of individuals with severe mental illness will find themselves in the system through a crisis. So we'll begin some questions on crisis, and I'm going to jump to Judge Brown to talk about the therapeutic diversion pilot that Jeff just referenced. Can you talk about how that pilot fits into the county's broader vision for diversion work?
Yeah, thanks so much. And yeah, Jeff touched on it, so I'm just going to drill down a little bit on that one subject of what Commissioner Howard really, I think, talked to Don and others at Integral Care about what is the thing we need to do, and this is kind of the start of it. The short version is we're doing a pilot to see what the things that we want to put in a mental health diversion facility, what things we can do now to learn a little bit about it, maybe focus our efforts on. And so the pilot was the county, originally the county, the city, and Central Health funding. I think now the county and Central Health are left doing the funding on this 3 or more year pilot that allows people, if they want to walk in to get mental health services, they can now 24 hours a day, and also gives us the option of housing people for up to 90 days, but only 25 people, because we're using the old Ronald McDonald House on 15th Street. And it's showing great promise. We're getting referrals from law enforcement. It's helping people not recidivate, also all sorts of great things. It's helping take people out of the jail to get mental health treatment. We just need more of it. And so I think that the short version on is the pilot working is yes, and we need more. And so that's why it's so important that the county and the city and Central Health and the state and everybody who has the dollars keeps looking at ways to increase what the work that Integral Care is doing in this area. My hope is that we will be able to continue this pilot, maybe hopefully expand it even while we're still building this building, which takes so long to do. I know we've also talked about trying to expand maybe with the Herman Center, some part of the pilot there to have an involuntary piece. But this is what we need. This is the biggest problem, maybe this is the biggest challenge that the county has, that I think we have in our little society here in Travis County, is people who, they get arrested. And I did a ride along with the CIT team last week, and they're right in the thick of this, and seeing how if people don't get mental health care access when they need it, they end up interacting with law enforcement, and it takes a lot of time and a lot of money. Sydney Harris led this study that we commissioned when you were at the medical school, 5 years ago to look at this, and it's a roadmap of what we need to be doing. They're first focusing, I think, on the people who are in and out of emergency things so much. Back then it was 108. I think now it's expanded to more than that in just the number of people, like individuals we first need to focus on. But if we can solve this or come closer to solving it, which doing what Jeff just said, helping people in emergency crisis, helping them get stabilized, and then helping them get into housing that is supportive housing, that's the thing. We need to keep heading forward. I think we have the resources if we all pull together and work together. So really just want to support what y'all are doing and say thank you for all the great work that you're doing in this area, and look forward to continuing to work with y'all. Yeah.
Thank you, Judge. Let's shift now. We just heard this fabulous study published in Psych Services on Austin being the first in the nation to have 911 callers embedded, 911 counselors embedded in the emergency system, such that you've got the fourth option. Do you need police, fire, EMS, or mental health? Sergeant Turner, turning to you, can you speak to the police department's perspective on the impact of having behavioral health counselors at the 911 call center?
Absolutely. So since the inception of what's called C3, we've seen such an excellent partnership, and it's completely essential for our community. When we are in crisis, a lot of us in society don't know who to call. So what do? We immediately just call 911. Traditionally, you would just see some sort of law enforcement, EMS, or fire response in those moments, oftentimes relying on law enforcement because we do have certain authorities in society. So we were being sent to many calls that really didn't have any reason for it to send a law enforcement professional when there wasn't, the crisis hadn't escalated to a point where somebody needed to be forcibly getting treatment. So we saw some of the stats a minute ago, and one of the ones I want to highlight is, since the inception of this program, we've seen around 34,000 cases transferred from some other resource. So when the person called, instead of it going to a law enforcement officer, it's going to integral care. They're trying to do de-escalate. They're trying to connect the person into some sort of resources. And every sort of diversion from law enforcement provides us the opportunity to address, for those officers to be available for those high profile calls, violence, whatever else are crime reduction in our community. And so the C3, we have seen tremendous results from it since its inception. And for our statistical data, we've seen a reduction in emergency detentions since that time period, as well as total case reports written. Every officer is required to write a police report when they come in contact with somebody in a mental health crisis. We've seen a dramatic reduction in that time period. And again, I go back to that is a perfect opportunity for us to send the right people to the right job. We have certain responsibilities, integral care does as well. We're very blessed in our community, and we've become the model, really. We had recently, this last week, we had another agency, law enforcement agency, come into town to learn more about C3 and how they can implement it in their area. So we're very blessed to have that.
Thank you, Sergeant Turner. That really does highlight treatment over incarceration or arrest that costs more money and has far less positive outcomes. Dawn, can I ask you to talk about our expanded mobile crisis outreach team and its role in the community as it pertains to crisis response? Thanks again, Judge Brown.
Sure. Our expanded mobile crisis outreach team, that project came to inception back in 2013. So we developed that in partnership with EMS leadership and LeVay PD leadership, and we've been doing that work since then, and it has grown and iterated over time, of which you've heard and seen some of the results. It's a national model. It's beyond that. Actually, we even had a consultation looking at Marissa. I just want to give her some kudos right here. Marissa Malik is the director over our crisis and justice initiatives, and because of her good leadership, we've been able to really make some remarkable changes in this program. And so what I was going to say is we had a consultation with someone from Canada. So PD in Canada is called and wanting to replicate the same thing. We get leadership from other cities and states, from Chicago, from California, from, you name it. And we've been having those consultations with states. And what we often hear after we're having these meetings is, y'all are doing it right in Austin. You're doing the right thing and you're doing it right. But we couldn't do this work without city leadership, from our council support, from city management from support in that area. And then just as you may have heard in the news, just within the last year, we've been able to expand this team to a 24/7 response. So if you call 911, you're in need of a mental health response, we'll have a team that can go out in the field 24/7 and meet you where you are in the community experiencing that mental health crisis. Some of the things that we do in this project is that we do this work alongside our first responder partners. So we're going out with EMS, we're going out with APD, sometimes we're all together, sometimes we meet out in the field because we call on each other to hand off cases. But the goal of that really is just to hand that call to the right level clinician to address the need that's occurring, right? And so then we can release our first responders to be available for other public safety needs in the community, so they're not tied up doing these calls, that we have the skills, that we have the skills and expertise in addressing. And so some of the things that we do when we're out there is the mobile team will be able to do a psychiatric screening or a crisis assessment to kind of determine what is going on, what is the presenting problem, what might be the good next step. So that treatment begins right away. It's analogous to an EMS response, right? So if you have a physical need and you're being called out and they're doing the quick assessment and beginning that treatment on your way to the hospital. So that's kind of what the mobile team's role is, kind of starting that treatment, what direction do we need to go, providing that support and beginning the plan right away. Kind of what is that interim action plan and what are the next steps? Do we facilitate inpatient admission or can we help resolve the crisis, which we often do at the time of the interaction, and folks are able to either go home or they can go to one of our other crisis services through our crisis residential or crisis respite services. So we've been doing this work a long time, and we value city leadership and our first responders in that work, and we're very appreciative of that work. And you guys don't really understand how difficult and how big of a lift it is when you change big systems. It takes a hot second. But we've done a really good job here, and happy to be a part of that work.
Thank you, Don. I want to acknowledge we've been joined by another trustee with Integral Care. We very want to be in the spotlight all the time. Krista Yana, thank you for joining us today. You heard a little quick reference to the first initiative, which is that highest acuity kind of constellation of Integral Care, EMS, and APD. Dr. Escott, turning to you, can you expound on what you're seeing as the effectiveness of FIRST, what it is, and kind of the data you're examining across the systems?
Absolutely, and thanks for allowing me to be here. Particularly with this fantastic panel who I love and respect and work with often. Look, the Austin First program was designed to ensure that for those highest acuity calls where there's somebody experiencing crisis, that we have all of the resources we need to maximize the ability to de-escalate, to identify the best path for that person, and ultimately to avoid as much as possible uses of force, emergency detentions that may not be necessary, and unnecessary transports to the hospital. All those things are expensive and not the best outcomes for the folks that we're trying to serve. When we launched this, we knew that there wasn't going to be a lot of numbers of these high acuity cases, but it's not different from the concept of having, I hate to use this analogy, but like a SWAT team. Right? It's highly specialized, but used infrequently, and that's okay. We have other things that they can do. I will say that over the 6-month period, during this pilot phase, only about 50% of those calls had a law enforcement component. So back to the point that was made earlier, we have lots and lots of calls still where law enforcement is the responder, but it's not really that. So Austin First recognized that. We knew that was going to happen, and we wanted to be a clear patient-first team. They are a patient-first until there becomes a law enforcement component. Having said that, our law enforcement officers in Austin are fantastic. And I've worked in other places across the state, across the country, across the world. they're special, and I'm not saying that because they're here. They're different. I respond in the field with them with the lights and sirens. I see them in action, and they care a great deal about this community. But the challenge we have collectively is we're not that good at triaging the calls. Okay? And it's not us, it's the whole world in emergency response, right? We have some systems that will triage and do as best as we can. But the key to success for us for the future is really enhancing that ability to triage. Because from my perspective, this is not the city's perspective anyway, it's wrong for us to ask the person having the emergency to triage the call, which is what we're doing. We ask police, fire, EMS, mental health. Okay? Sometimes they're spot on and sometimes they're not. As it relates to mental health crisis, folks aren't that good, right? Particularly when they're stressed. They hear police first and they choose it. My opinion only, the future across the globe is going to see AI used much more substantially in the next 2 or 3 years. Because when we talk about cost, and we're all facing cost restrictions, and I appreciate the exercise that the city and the county is going through to reassess things, but the services that we provide are expensive. And if I can just contextualize that for a second, to send one ambulance on one call, it costs the city $1,351. If there's a fire truck on that call, it adds $2,200. Those are very expensive resources. And we are not utilizing funds well when we send that and it's not needed. I can send a doctor or a PA for $290. We can send integral care by themselves for a whole lot less than that. So we have to do more work to triage more accurately so that we can conserve resources and provide the people the service that they need, not what we think we should give them. So I'll stop there.
Well said.
Sergeant Turner and Dr. Escott, as our first responder partners, what gives you confidence that we're more or less headed in the right direction? And what critical next step do you see the need for us to do together? Sergeant Turner.
I'm confident because I know we're doing it together. I've been blessed in my career. I'm coming up on my 20th year in September, and almost a decade of that has been spent solely in crisis intervention team world. And so I've seen it grow and expand our collaboration with everybody up on stage. We were joking earlier, me and Marissa, about how we see or talk to each other almost every day or weekly now, just because we are so collaborative with all the different agencies and all the different programs we have. So I know we're seeing it in the results in our consumers that we're interacting in community, the times we are able to jail divert and de-escalate situation to people the right services. I think one of the critical steps in the next is just more integration, fully integrating all the mental health programs together, so we have a consistent response to everybody who's in crisis, that we get the right people there in the right moments. Not every time requires a law enforcement presence, not every time requires an integral care employee. There's always different types of situations that we have the ability to continue to grow and evolve. And I think support of all of our various programs like Austin First, No Wrong Door High Utilizer Program, the Jail Diversion and Hospital Diversion Center that I know that Judge Brown has been working tirelessly on, that we desperately need in our community. Programs like that need support from the community. They need the funding necessary so that my officers, when they're in doubt, they know where to take somebody. They know who to call. And the community as a whole gets the best response. So I know that we can be a model for all of Texas and all of America, really. So.
Thank you. Dr. Escott?
Yeah, look, there are many next steps, and I agree with everything he just said. But it really has to start with community values. We have to decide as a community, is mental health care something that we value? It's always going to be more than other things. I've had the privilege of living and training in a different country, in Australia. And it is evident in places like that, the community, the country values this. They value supporting each other. there is a safety net for everybody. We don't have that same value here. And the only way we're going to change that is collectively deciding we choose to value this thing. And sorry if I can just pontificate just a second. And I'm so excited about C3 and, you know, having mental health in the 911 center. That's great. I will tell you that when I trained in Australia 20 years ago, it was already happening. That's how far behind we are in this country in creating systems of care that work. 20 years. We are the wealthiest country on the planet. We have incredible connections. But we have to design systems, we have to change our values in order to solve these problems. I'm sad that Judge Brown isn't here because, you know, I always think about COVID. I hate to bring up the C word. But that was a monumental challenge for this community. And this community came together, city, county, integral care, central health, every person. And we hit it out of the park compared to every other city in the United States. We had lower rates of infection, lower rates of death, lower rates of unemployment than other major cities in the US because we came together. Mental health is a war that never ends. And we have to choose to win the war, not to win battles over and over and over again. So we've got to come together. We have great collaborations. We've got to improve those. We've got to bring the community in more. We've got to get the public engagement. Because at the end of the day, the big rate limiting step is fun. It's fun. So we also have to do a better job of sharing that value proposition with the community so that they can get where we are, where we know, because we're there and experience all the time. Everyone else doesn't. So I think that's what we have to do to be where we need to be, funding-wise, public support-wise.
Sergeant Turner and Dawn, what key message do you want the community to understand about how mental health crises are addressed in Austin Travis County?
I'd like to say we have a robust and very collaborative mental health system within our community. The relationships we have up here have taken a long time. When I started in 2012, I had an amazing lieutenant named Lieutenant Chris Thompson, and she worked with Dawn a long time ago to get us on this path to where it is second nature for our officers to contact integral care, to interact with integral care. It wasn't always that way. And every day I rely on them to help me with all sorts of different programs, assessments, et cetera. We're just very blessed to have that collaborative relationship. They come to our training. All our officers in the Austin Police Department get trained by integral care staff on how to de-escalate topics such as mental health conditions and where to get people help when it's all said and done. We're problem solvers in law enforcement in the end. For years it was, hey, just figure it out yourself. And what did we do? We ended up arresting this population more often not because we didn't know what else to do. We have the tools now, but we still have room to grow. We cannot do it alone. We have to continue to have the support from the community, from integral care, from everybody up here on the stage to build a better program in our community, because we will be the model, I know, in our community.
Thanks. I want to just make a couple of comments off of what Dr. Escott shared and Sergeant Turner related to kind of the value piece. So as we kind of address the problems in our community and we look at kind of where the gaps are and what services we've really relied on champions in each area. So we need a law enforcement champion, we need a medical EMS champion, we need a central health champion, you know, somebody at the county, like the judge, I mean, all those kind of things. And when those positions turn, you almost have to start over again, right? So I think what's important is that we build these systems into our fabric, which feeds off of what Dr. Escart's saying around value. Because if you value that, it lives in your system of care. And then it's muscle memory. We don't have to worry about who we have to go and talk to leverage the resource and get the funds, because that's really what it's about. We know what works. We're building the thing that works. It's showing the results. The data is there, but it's not to scale. It's not at capacity. And we live in a place where our population has grown exponentially, but the resources to meet people who are living in our community have not scaled with their need. And that's our responsibility as leaders in this community, as providers in this community, as experts in this community around mental health. If you don't have that foundation built and strong, then the other things will not come along and you will struggle. So that's building that system of care. Now, integral care is a piece of that puzzle, right? And we're the experts in the community trying to bring and leverage kind of where the gaps are, how we can infuse some services there, but we can't do it alone. We need the help from our first responders to do those things, from our healthcare providers, because when you're addressing kind of that healthcare need, that mental health need, that public safety need, you get better outcomes for individuals, and not just some individuals, all the individuals. So we have to move our system to meet their needs instead of having them fit into a box that we've built, and then we're going to see success. So we have, as a local mental health authority, a system of care, right? So you can come into our, call our hotline, our 988. We are the 988 provider for Austin and Travis County, or we have a helpline, 472-HELP, to kind of access that care. But you don't just have to call that number to access crisis services. You can access ongoing care that way too. So just kind of one place to go, and almost to that triage piece. Then we want to hear what that presenting problem is. What you don't have to know what you need. You just have to know who to call, where to go. And we're going to navigate that pathway for you and hopefully have along that continuum all the things that you need from that crisis service, residential care, inpatient if you need it. But really the goal, because we see better outcomes that way, is for that least restrictive community-based care. It's not only less expensive, it's just better for people. You know, you think about a time you've been in an inpatient, you've had surgery, and you're like, gosh, I can't rest. You know, I had the thing fixed, but I'm still really tired. You don't really start recovering until you're at home. So these community-based services, which is our thing, that's our jam. We do that really well. Not everybody does, and we want to do it. And bringing those services to you through our mobile services in crisis and through our mobile services in our outpatient. I'll stop. I can go forever.
Yes, I was going to switch gears now to access. So moving away from crisis response to access. Is there anything you want to add, Dawn, on if somebody doesn't even know where to begin, what they could do to reach out and get the right care?
Yeah, just call the helpline. Mm-hmm. So just reach out, call 472-HELP, or if you can't remember that, and you remember 988, that's us too, and we will have a clinician. We'll be ready to take that call. They're trained. They can work on de-escalation. They can provide that support on the phone. They can help develop that plan on what the next steps are. They can help you make that outpatient appointment if that's a service you want with us in any of the areas where we have outpatient clinics, and we can do that there. And then the neat thing about our crisis services that I didn't mention earlier is that we're going to follow you for up to 90 days. We want to make sure you make that connection with ongoing care. We don't want people just seeking their services in a crisis system. We want them plugged into that outpatient ongoing care where they have that continuous support.
So switching to the discussion of whole people, you know, we've talked a lot about mental illness, severe mental illness, substance use disorders, but people also have physical health conditions. About 70% of those that we serve have comorbid and chronic health conditions. And I'd like to talk about our systems and turn it over to Jeff and Sydney. What are the opportunities and challenges in integrating behavioral and physical health symptoms? Systems and systems.
Great, thank you all for having me here today. I appreciate being on this panel with everyone. When you think about the opportunities for integrated healthcare and behavioral healthcare, we don't want to care for the brain separately from the body. We're all one, right? So integrating together the behavioral and physical healthcare helps us create a space where we're caring for the whole body. It also allows for earlier intervention, you know, going upstream. Once you identify a mental health or substance use, it's better to identify that and start caring for that earlier than downstream, that's where you then get into crisis needs, inpatient stays, which becomes more expensive. And sometimes you don't know where to turn, and maybe you're, you know, getting met by a CIT on the street, and that's not what we want to do. We want to go upstream and create earlier interventions. And then also it decreases stigma. When you have the opportunity to go into your physical provider for care, and that physical providers asking about your mental health or your substance use. It decreases the stigma of needing and having fear to reach out. You know, mental health is talked about a lot today, which is wonderful, but there's still stigma out there. People are still afraid to get the care they need. And having the opportunity to go to their primary care physician and talk to their primary care physician about their mental health needs in that setting decreases their stigma of having to then reach out to somebody else, and also having that warm connection and handoff to mental health providers.
So, thanks, Cindy. I think the other thing, and I want to sort of echo Dr. Escott's sentiment earlier about, we count on a lot of people being able to triage themselves. And really some of the work that we're trying to do now, Don mentioned the call center, but between all of our partners here in town, everyone here has talked about how well we're working together. Now we need to deepen this and do a more sophisticated, more version 3.0 of this, which is now how do we start determining what's the most efficient, effective place for someone to get the care that they need. In some cases, it may be through their primary care doctor. In other cases, it should be through integral care. In other cases, it needs to be in an emergent crisis and with our criminal justice partner. But what we need to do now is interlace these services. We talked about data exchange. We also need to be much more effective about what's coming ahead. You heard us talk a little bit about the use of AI, but how are we screening people, and how are we sharing that so people don't have to endure multiple screenings? How do we ensure that that data flows across different programs and services? But the other thing that's really imperative is when someone's getting medical care, how can we ensure that they have access to behavioral health? Because we've seen the drivers of overall health costs and people's medical outcomes go way up when people have access to behavioral health. People with heart conditions, people with diabetes, people with a range of comorbid medical conditions. When we pair that up and match that effectively, and we as a community do a really thoughtful, organized way about how we approach where people get their care. I've used this analogy way too much, and Don might throw something at me if I say this, but I really feel that we still kind of, I have a granddaughter, so I think about this all the time now, about how little kids play sports. They all chase the ball at the same place. How do we as a community effectively coordinate how we deliver the services that we have? Because we don't have the resources to do it each of ourselves independently. We need each other, and we need to now be smarter about how we coordinate overall health costs, because they're diminishing. They're not just staying the same, they're reducing, and the demand's going way up.
Jeff, you alluded to this, but could you explain the 4-quadrant model and the challenges it's designed to solve?
Happy to do it very quickly because I want to make sure we have time for questions and I don't want to bore you all. But one of the things that's important, just tying into what I just said earlier, is there's an approach to how people and where people get their behavioral health services. If someone has a very low intensity need for mental health services, their primary care doctor can do that. But when they're struggling, that they need to be coordinated, and that work needs to be done with a mental health professional. And done, in some cases, mental health professionals need to be on site and coordinated that. The same goes for housing services, criminal justice services, all the above. How do we ensure that the right level of intensity of services is following where that person needs care? So I'm used to teaching classes and showing it up on the screen. I'm not going to torment you all with that. But to summarize, it goes to that the 5-year-olds playing soccer. Where do we deliver the right set of interventions, and how do we optimize all of our systems of care to ensure that if somebody needs more intensive services, they can get them at the right spot, and when they don't need them, how can we coordinate that with a primary care physician and emergency physicians and our inpatient partners as well.
Thanks. Sydney, segueing to specialty care, can you expound on what program Central Health has recently adopted and how you're collaborating with both community care, a local FQHC, as well as integral care?
Sure, happy to. So one program that comes top to mind that was, lack of a better word, birthed from everyone together was the Permanent Supportive Health Housing Healthcare Collaborative. That came together with ECHO, Central Health, Community Care, and Integral Care. And we looked at it as a whole system. How do we support individuals that are coming from being unhoused and moving into their permanent supportive housing, providing them with all the services they need once they get into that space, and how do they maintain their housing as well as increase their health care and their mental health care so they can stay housed. And that has been running maybe 2 years, 1 year, 1.5. So it's in its infancy, but it's doing great. And we all came together, you know, we broke the silos down and we worked and created a program across every silo to help those individuals. Other programs that Central Health is doing, looking at the ecosystem and the gaps that we can help individuals, is our medical respite and our transitions of care. Individuals that are medically complex and are also challenging with mental health and substance use. We are integrating in those facilities, and then once those individuals are ready to return to the community, we help them connect back to community care and integral care. So they're also continuing their whole health outside of the facilities there.
Thank you. So before we move to audience Q&A, Jeff, I'll invite you to expound on what's next for integral care.
Yeah, there's a lot, actually, thanks for putting up the slide. There's a couple things that's just the community should know about. One, we are really excited about Seabrook Square 2. There is a Seabrook Square 1, but that's a different housing program next to ours. It's a 60-bed permanent supported housing. We are thrilled, and we'd love you all to come out and visit. It's really extraordinary. And again, the value of this program is not just the housing component, but the support component. And I have to keep reminding everyone how critical that is. You heard Dr. Escott talk about how people rallied around during COVID. We've also seen a rally around building affordable housing, but that's only part of the formula. And for people to maintain that housing, they need supports, and they need reliable, consistent supports based on their level of need. Because if we're providing a house, we celebrate a ribbon cutting, and we don't provide the support, we fail. And our whole community needs to keep that top of mind as we look at all of these initiatives that are building. How do we ensure people maintain the momentum and success that they have? And this program is a great example of it. The other thing that's not as sexy, but even more exciting in some ways, is that what we're trying to do is we're updating our website. And when we do that, we have a lot of people who use our website, particularly as an LMHA, for a lot of different reasons. Some for information, some looking for a job, some looking for help. And a couple of our panelists have said this, but it is like a secret handshake you have to understand how to get the care you need and understand it well. You need to know the right words, you need to present the right message. And a lot of the work that we do behind the scenes is helping decode that and help people not just know, and we're trying to build that into our website as well. And some other tools that we talked a little bit about the use of technology, AI. We're not replacing our staff with chatbots and AI agents, but we are going to be starting to use what we can, because we have to be more thoughtful and efficient about the resources available. And we are going to be employing a lot of new technology, not just in our website, but across integral care over the upcoming months. And then the last, we've heard us talk a little bit about our vans. And a van itself is not very exciting. We walk in a van, it's not, but what we're doing with these is pretty unique. We just came from a meeting in Denver, Colorado, where 6,000 people traipsed through our van, and people were just amazed about how we were using this. And again, as you heard earlier, this is a growing community, and how we reach people, we should not expect that they come to us. We have to go to them, and we have to find more creative ways to do it. The van itself is great. The technology that we're putting into that's pretty remarkable, and how we're using this over time is going to be really up to our community to help us to use that most effectively. I'm not going to go through this because I want to make sure we have time for questions, but suffice it to
I
say,
like the colors, Jeff.
I'm colorblind, so asking me to talk about colors is like, they all look good to me. But we spent a lot of time with our community members really talking about our new website, our new logo, and our new identity to talk about what would help us visually represent what we do as an organization most effectively. You go to the next slide. Really, there's two things that we felt very strong. We heard from the community. We're here to help people's brains, right? In a number of different ways. But we do this with our hearts. Those have to work together. So we came up with a new logo that reflects both of those things. And so that's our new logo and our new, no, we didn't spend millions of dollars on this either. So if you're asking. Many people spend millions of dollars, nobody specifically. But what we did do is we really got a lot of great feedback from our community folks about what was important about how we reflect who we are as an organization. And we felt we needed to refresh that. Next slide. So I think now, oh my gosh, we're over, but we have time for questions?
We're going till 12:30. So
Oh my gosh, well go on, give me that slide back, I'll tell you more.
So we will now invite questions from the audience. We invite you particularly to stand up at the microphone if you have a question. We have a hard stop at 12:30. If we don't get to all the questions, you can email us. We'll provide that email address. And you can use that QR code if you're not comfortable going up to the microphone and or you're comfortable with us addressing it at a later time. That's another modality. So invite any questions.
No math questions.
And if you introduce yourself.
Sure.
As well.
My name is Lisa Miller. I have two questions. The first is about AI, and I don't expect an answer, but it's a concern. And it's kind of training that appropriately. Obviously, you all know that, but I actually had personal experience with a misrouted AI call because I used too much medical terminology and it freaked the thing out. So anyway, that's just my one comment about AI. And then secondarily, interacting with the community, bringing services, and then we get a determination that somebody needs inpatient care. How does that next step, how do you determine the best facility for a person to go to other than it's just an available bed? That's my question.
Yeah, I'll answer the first half, and then I'm going to ask maybe Don to talk a little bit about sort of our inpatient process. But on the AI front, I appreciate what you said. For us, we are using AI in two very specific ways. One is around sort of internal administration, and just not to go into a lot of depth with this, but know that Integral Care specifically, we have over 400 sources of money that come in, 200 plus grants. None of them are written the same, right?
Mm-hmm.
So we have an enormous amount of variability and sausage grinding that we have to do, and administrative costs and time with our current systems. So we're investing in using AI to help us reduce some of our administrative costs, hopefully, and help us become a lot more efficient, because we have to. We're not getting more dollars to do the same thing. We have to use those differently. On the patient-facing side of things, we are not using AI at all to replace any of our clinical staff. We're using it as an adjunctive tool. And I'll give you an example of that. We do use it right now to help people who want to, we have ambient listening tools, which help document with the permission of the patient, 100%. And that information is immediately deleted after that session, but it's used to both document and help identify potential areas to focus in on. And we've received really good reviews on that and how people are using it. We're also using it to measure quality, to track how we're documenting and what we're using to ensure that we haven't missed anything. This also happens in our calls. It's helping us identify potential suicide risk with folks. So there's lots of really tools if it's working on the side of something. But you also heard Dr. Escott say it earlier. One of the things we're looking at too is how do we help streamline and organize how people get help in a way that's more efficient. But keeping in mind that we're not handing the keys over to an AI system to do that, but one that we curate and design, and hopefully one that we can standardize across our community. But on the inpatient point, there's a number of decisions about where and how we identify inpatient beds. And Don, help me with this. We can tag team this. But we have within integral care, we have a process. We have grant dollars that are given from specific sources that identify who and how we can use those dollars. Some of them are specifically for competency restoration dollars, and some are for people's need for inpatient capacity who have no other resources. And based on availability of beds, location, where that person's best experiences are, and frankly, our resources that we have available, all of those decisions are how we weigh where and what inpatient beds someone gets referred to. Did I catch everything well?
Yeah, I'll just add a little bit if you don't mind, to specifically kind of answer your question around kind of how do we determine what the best place for someone to go, like which inpatient facility is going to have the tools and expertise to address your particular needs, or your neighbor's particular needs, or my particular needs. And we do have contracts. We do receive some dollars from the state through Central Health for inpatient bed capacity, right? So that we contract with various providers in our community. Some of them are private hospitals, some are in our community, some are outside of our community because we don't have enough inpatient bed capacity because we have an issue with ASH, right? And so when you're kind of looking at where do they go and where's we really need access to ASH beds and all the things that entity can bring to really individuals who are having really complex needs. And not all the private hospitals can do the same thing that ASH can do, and ASH doesn't do all the same thing that some of the private hospitals. So there might be some that specialize in eating disorder, right? Or some that are better dealing with depression or anxiety. So as we're kind of looking at, say, law enforcement and the mobile team are out, or you've called the hotline and you're identifying what your presenting problem is, and we'll hear those things. And then we'll determine based on, where we have that bed capacity with various providers, based on what your need, what their expertise is, and availability, right? So it's all the things to try to make that a good match. It's not all encompassing. There are still some shortfalls, and we still need some inpatient capacity to really deal with some of the higher acuity, high intensity, very complex cases that we have here in our community. So we're not there yet as a system. Integral Care is not providing those inpatient services yet. But we are working with our partners and with Judge Brown, with the commissioners, with city leadership, and Central Health, as well as DelMed, on trying to develop where is the gap, what do we need to kind of fill those inpatient needs out so that we have better access for you guys when you need it.
I would just add on to that, just a clear statement, is there's not enough beds. Let's just be clear about that. And we need to be in a position where best option isn't to go to jail for inpatient capacity, but our community can fully meet the needs of the inpatient needs in a way that's coordinated with this wonderful system of care we've been talking about, that we create a true ecosystem of these services. And I think we have to decide, is this a value our community needs and wants to support? And as Don said earlier, all of us are working together to kind of come up with some solutions to build on that. But it's insufficient. The numbers of beds on average nationally range from about 30 to 44 beds per 100,000 people. We're well below that. And we have beds, but there's, as Don said, they're simply not as available because there aren't other options for people who are in those beds to go to. So some of the other work that we're doing, and you've heard us talk about, this isn't just to say how fabulous everything is here to you all. We have a lot of work to do. And not just, Don mentioned scope and scale, but it's also really building out where we see gaps, both in inpatient and high-intensity services for people who don't need to be in jail or in a hospital, who need transitional levels of care.
If I can jump on that for a second. The question you may be thinking is, why do we have a shortage of psychiatric beds? I can tell you, as a physician that works in hospitals, we don't have a shortage of CAT scanners. We don't have a shortage of MRI machines. We don't have a shortage of beds if you're having a heart attack or a stroke or you're having a surgery, because those things pay. This is about the value of mental health care. The problem is it's not a short-term win. It's a long-term war. So it's more difficult to conceptualize return on investment. We need legislative action. We need CMS to act to increase the funding. That's the only way you end up with more beds, if there is an economic reason to do that versus having an MRI machine or CT scanner. I do want to, if I can, answer your AI question, which is fantastic, regarding the 911 system. We don't use any AI at the moment. The AI tools that are available right now do not replace decisions. They don't make decisions. What they do currently is, when you call in, you may speak one of a bunch of different languages. It will detect the language and translate in both directions. Okay, right now I can tell you, in our system and systems across this country, if you are making that call and you don't speak English, there is a delay in care. And that delay in care impacts outcomes without question. It solves that problem. When you start talking, we can program in keywords for it to recognize. Okay, as an example, one of our primary call types that come in, which ends up being a mental health crisis, goes to APD, and it's a criminal trespass. Okay, so we can program in trespass, naked, breaking glass. And AI can identify those keywords for the person triaging the call, and at some stage recognize and recommend mental health, or mental health plus law enforcement, depending on the situation. But it also does simple things like translating speaking into text. Okay? We waste a lot of time. The call takers have to hear correctly, and they have to type it in. This takes care of that. The person says it, they look on the screen, they verify, it goes in, which reduces the time it takes to process the call. It reduces the errors associated with transcription errors. And let me tell you, if you say I-35 North instead of I-35 South, that's a big problem if you're having a time-dependent emergency. Now, what does the future hold? The future would likely hold recommendations. I recommend that you send an ambulance, a fire truck, and a police officer, and you respond with lights and sirens. That is probably coming at some stage, but we're nowhere close to that at this stage. And the technology right now that's available does not offer that. But the better that we can get at accurately triaging, which is something that only AI can really do, because it will take my experience and all the call taker 911 experiences and put them together. The better we can recognize patterns, the better we can manage resources, and it gives us the opportunity to reinvest resources more appropriately, to have that transparency, to have that fiscal responsibility that this community expects.
I have a follow-up.
Yeah.
If there's not another.
Go ahead and follow up mine with a different question.
Okay, so how do we measure if there are various places to send people inpatient? What are the quality outcomes in the field that we are looking at to make sure that we're sending people to safe places? Because I have grave concerns about some of the facilities in our community, and yet, because we have shortage of beds, it's just a never-ending machine. What kind of quality measures do we make sure that these people are being released to a safe environment that's gonna help them get better?
Take that.
Yeah, I'll start, and we've been tag teaming these very well, so you can help all the things that I get wrong, Don.
You bet.
But I think there's a couple things. Number one, the organizations that we work with, again, none of them are connected to our services. We contract with a number of different partners. Those entities are typically, for their own certification, are required. They need to be joint commission. They need to be nationally certified for what they do in this work. Specifically on the outcomes that we look at is recidivism. How are they coming back? What happens post-discharge? What's the disposition of that person at the time of discharge? What are the outcomes that that person wanted to get out of that inpatient admission? And were they successful? And frankly, availability and accessibility of those beds when somebody actually truly needs them. And then, based on the population served, that varies. So some people who are experiencing a very specific crisis, it's establishing how they resolve that specific crisis. Other people, if it's children or adults with special needs, identifying what clinically are the outcomes that they presented and how did those inpatient partners actually meet that. But I echo your concern. I think it's an area that we, not just having more beds is not the approach. We need very specific needs that need to be addressed. We've talked a little bit here around it, but many of the folks that struggle most in our community need both very specialized care, meaning folks with comorbid medical condition and mental health needs, substance use needs, having a clinical team that will meet those effectively, and if someone needs medication, effectively evaluating the quality of the medications that they are on, if they're on anything, and giving enough time for that person to monitor how successful they actually are, and a well-coordinated transition plan. Those are the metrics that we look at. Now, if you're going to ask me, are they always met and attained? No. And I think we do a lot within our organization to monitor that. But as you said earlier, we don't simply have the largest number of beds that we need in this community. Don, anything you want to add?
No, I think you covered it, other than we do, any of the contracts that we have do have deliverables and metrics and quality measures that we're tracking. If a provider is not meeting those standards, then there are consequences to that, whether that's withholding payments, asking for a plan of action, addressing what the gap is, but not just that, but giving them tools, training, and to help them try to resolve those problems so that care does improve. It's a little bit more difficult upon the discharge piece, just because we are serving such a high number of individuals who are homeless. Not everyone has that family support or a place to go, but those are definitely incentives that we want to build into those contracts, which we do have. So when those things are met, then that's added. So those are things to kind of get the hospital to do more and help coordinate more, so we have better warm handoffs. But I don't disagree, and I understand that there are challenges. I see them as well, and we're doing what we can, but we're one entity, but there are also those state, federal guidelines that they have to follow as well.
And this is material that's available publicly, who you contract with?
Yes.
Okay.
So the other thing I would just add with that too, I think it brings up where it's important for us to keep building in our community in terms of options. We talked about inpatient, but also step down capacity. So if someone doesn't need to be in an acute phase of need in a hospital, they have a place where they can get ongoing support for as long as they need it, and that we're able to follow, and that person has a clinical team that follows them wherever they are. All of those are things that are really important for us to keep building and keep our eye on as we keep building out the systems.
Vanessa?
Yeah, hi.
Welcome.
Hello, friends. I've seen my name is Vanessa Faria. I'm with Cardia. We're actually supporting the substance use planning process that's going on with Communities for Recovery. And I used to be the executive director of CAN, and it took a long time for the partners to kind of figure out, come together, Central Health, City, and County, to say we need to work on substance use collectively. It took probably a decade. Trish, you might remember those days. Yeah. So, as I've been in this community for 30 years, and I live in District 6, far away from downtown, and I see the needs, I'm thinking, well, where's the planning upstream? Which partner is focusing on population mental health? Is that Austin Public Health and the CHOP-CHIP process? Like, what are we doing to get information to people upstream, my neighbors? Is it appropriate for them to be calling 472 help? Or should they be accessing other information elsewhere? And my question to you, I'd love to hear, is what are other communities doing to really promote population mental health upstream so we're avoiding people going into safety?
I mean, I'll start, but I would just echo what, I've been quoting Dr. Escott through this whole panel. But he mentioned other countries have done this. I think there's a value that, I think to answer your first question, yeah, they should call us. And we can help troubleshoot within Travis County what those particular needs are. If they're calling 988, also, we will help them triage wherever their community is for the most accessible, available services. Now, when you're talking about upstream, you're talking about promotion and prevention at a high degree. And this is something that I think all of us are taking on in different ways across our system. I mean, even the mayor has been talking about the city of Austin being a place for, a destination for kids and children and families. Well, there's lots of pieces of upstream and promotion and prevention we are doing with schools. I know AAIC is working on them. Our other partners across different school districts are working on. I think the population strategies and clearly seeing where there's gaps in service and flow. One of the things that I come from the Northeast where there was a different strategy. I don't think this community has done remarkable things collectively, which I have not seen happen in other places. But what we also struggle with here is foundational access to things like Medicaid and healthcare for those prevention and promotion services. And I think that is a piece that we have to tackle as a community. How do we ensure that everyone has access to prevention and promotion services without having to get arrested into care, without having to show a high level of need before services can be eligible for? So that's as much as a political issue as a planning issue that we have in our community. How do we ensure that all the resources are available for people when and where they need them? Now, on a broader statistical and strategic basis, we are working with all of these partners to come up with a more organized way to tackle this. And I would urge you, if you can, look at our plan that we put together on our website. It's not substantive as it should be. I want it to be more. But I do think this community has responded to the cards we've been dealt in terms of why so many people are in more acute downstream utilization of behavioral health services. I think one of the things that we see, and I think you've heard a couple of different panelists say it differently, funding prevention and promotion isn't always sexy and exciting to do, but it pays off down the road. And and I mentioned early on when we talked about mental health first aid, it seems a bit of a novelty to some people, but I think it's a critical tool to help people identify where and how people can access care early and often. I think helping kids in schools work specifically on things like executive function, how to help kids identify how to access care when they need them. Having families, giving them the tools to support them are all really pieces that we all have to carry with us. We know there's a lot of evidence about what those tools are and how they work. We need the resources to tap into those.
A quick question for you. Okay, so somebody is feeling blue or anxious. And I know, I used to work at Integral Care. Integral Care is working with the most critical people. I would never want to call to take up space where there are people having those needs. So if I have a friend that says, who do I talk to? Sure, they can go to their primary care physician, they have 5 minutes, and they have a prescription maybe, okay? But I don't know I don't feel comfortable, honestly. I wouldn't feel comfortable directing them to 472 help, but I guess I should.
You should.
I
should.
Because we know there's not a lot of resources, so we don't want you know?
So
and-
let me answer your questions
Yeah.
more specifically. We also have a network authority function. And within that, it doesn't always mean that we're delivering that care. We may go, you know, Jeff, you've been sniffing glue for a while. You're a middle-aged, I'm generously calling myself middle-aged at this point. Struggling with a number of issues. Let me refer you to our partner in the community who does this specifically for you. Or we do have a network of partners that we work with to connect people. It's not us being the sole arbiter and decision maker around what services we deliver. In some cases we will, but I would put a lot of confidence in people calling our 988 call center to help at least identify what their needs are. And I think it's so important in this work is that we've said it a few different ways in this meeting. We count on a lot of people telling us what they need. Our teams do a really good job of helping people identifying what would be the best resources to help meet their goals. And it widely varies from people with acute psychotic needs to people who this is their first experience with a mental health need. So our team is pretty tooled at that, but we are not necessarily people to do everything ourselves. That goes to the soccer analogy we said earlier. Where can people fit in to get the right supports? And if we're seeing patterns, and one of the things that we do a lot is we look at the data that we're seeing based on services we deliver to help us identify further gaps. And if we have time later, we can kind of recite those. We have a lot of targets around areas of gap that we've identified, not just that we'll deliver, but how are other partners. And you heard our discussion with Central Health. We're doing a lot with Central Health and community care to identify who should be doing what set of services so that we're not falling over each other in a very limited resource community we're in and doing the same thing.
I want to say one thing before you go. It's lovely to see you. I feel like I haven't seen you in a big hug, and I will before you leave. But you bring up a valid point about all the planning and the coordination, because the city does a planning thing, the county has a planning work that's happening, and how do we overlay? We're doing planning work with each other. How do we overlay those planning efforts to kind of see what's rising to the top and better focus our efforts? And that's stuff that we're trying to do in our collective work. So I just want
No, that's great.
to add that piece. But please do call the helpline, because we do have the list of resources. And if it's not something we can do, we can connect people.
And I'm gonna add on, I'm from Houston, so, you know, this whole Austin thing was new for me, started about 10 years ago. It took me in my role and as a physician in a local ER about 5 years to sort out what's the difference between integral care and central health and community care and peoples and all the things. We recognize that's still challenging, and part of this collaborative process is how to make it clear for people. We know at a baseline in the United States, our health literacy falls behind most developed nations. When you talk about healthcare literacy, sorting out what resources to access for diabetes, high blood pressure, whatever, it's gonna be worse, right? So we have to have a broader discussion. How do we improve both of those two things? Because there are many circumstances where there are available resources and people have no idea, number one, that they need it, and number two, how to access it, even when it's there. Now, the access issue is the different subject, but we're talking about people with health insurance, people with Medicare and Medicaid, veterans who don't know how to navigate the system and end up on the streets when they have access to incredible resources. The only way to solve that is together. I'm going to pontificate for one other second. My wife was a high school counselor in an ISD in Travis County. You know, we depend on schools a lot to do things like health education, mental health education. When we have events, you know, like Uvalde, and we look back and we see a young person who had significant warning signs of mental health issues, we ask, well, why did the school sort this out? Why did the school counselor sort this out? My wife has 400 kids that she's responsible for. She is trained in mental health. How does she spend most of her time? Doing schedules in college prep. We have a malalignment. We have the people, but we're not investing in where we need to, right? Our school counselors should be focused on counseling, visiting with students, following up, having the freedom to do that. I'll take the state has done a good job of increasing those investments. It's not been good enough. So we have to strengthen, that is one of our core screening processes, because we all know that's when all of these things start. And we miss it, we pass it along, and that is about the most upstream thing that we can do, is invest in mental health in the schools. And connect the services.
Thank you.
I'm gonna add on to your add-on. One other thing that we just need to,
In 10 seconds.
I reclaim my time. Just really quick, just about the private insurance market that we're in. And that so often many people go outside of their own insurance to try and access behavioral health care because of the rates that are not sufficient, even if you have insurance. Having a little bit of insurance in this country is pretty bad, because people end up utilizing other resources and demands, and it alters the market here dramatically for prevention and promotion. And we need to do more to look at how those profits are rolling back into actual care versus the pockets of the executive leadership of these for-profit entities.
Dawn, do you need 5 seconds?
No.
Okay. Thank you, esteemed panelists, and thank
Do
you
you have one
all.
more question?
I have a really quick one.
Okay, come on.
My name is Jessica. I'm with Community Impact, but I was just wondering like what members of the community can do besides reaching out that phone number, but what they can do to support health, like getting the word out, anything like that.
Yeah, I would start with what a plug I said about mental health first aid. And the reason I think that's a good entree for a lot of people, it helps understand what you need to look for if someone's struggling with mental health. It helps identify, it helps people, it demystifies this. It helps people identify if they're seeing people struggling, because many times people's friends, family, and community members are the first people who are going to identify that. I think the second is really supporting and reduce any chance you can both advocates at a state, local, and national level access to care. And how critical it is. And you've heard all along, the promotion piece of this work is really important. So anything you can identify, if there's anything, I'm sure anyone in this panel, we have some amazing, talented people here who would probably love to come and talk to you.
I'll add on, you gotta show up.
Right.
You gotta show up at community events, you gotta show up at city council, you gotta show up at commissioners court, you gotta show up at the legislative session. Again, we have to value this thing. The last thing I'll say is, we need to sort of relearn how to be a community again, right? In this internet age, social media age, we're all very disconnected. We've got to redefine community. We've got to bring back some of the things that happened when I was a young kid in Houston, and parades and community events and block parties, and there's no substitute for that human contact. And I think broadly that's something that's easy and it's free. We got to start doing that.
I would say lead with kindness, have that compassion, and don't be afraid to lean into that, and then step up for your neighbor.
Thank you.
What a beautiful note to end us on. Thank you for your question, and thanks again to the panelists. Thanks to all of you. We'll invite you for food and water and anything you need. For any members of the media that are here, Moonji Nyford is our coordinator. I think any of our panelists would be delighted to be here.
Today.
Thank you so much.
How are you,
I know all the reasons why.
Ready?
Yes.
Want to take some